Good afternoon, everyone. Today we will be discussing pulmonary edema, something that we are very familiar with having gone through a pandemic. So, causes of pulmonary edema. Pulmonary edema is leakage of the intravascular fluid into the interstitium and alveolar space. So, if we look over here to the left, A is normal. We can see we have normal pressures in our capillary beds and normal pressure in our alveoli, versus here in B, there is increased capillary pressure, and that's going to force fluid into the alveoli. So our capillary pressure here is 50, and it's going to be pushing fluid in, and compared to C, which is an increased capillary permeability. So even though the pressures are relatively normal, fluid will pass easily from the capillaries to the alveoli, and it'll have a high concentration of protein and secretory products in the edema fluid. So as you can see here, there are more areas of permeability allowing the fluid to enter the alveoli. And we've probably seen hundreds of x-rays that look like this. But here on the left, we have our papillary edema, which indicates increased capillary pressure. And here on the right, we have our diffuse edema, which will indicate increased capillary permeability. We have two types of pulmonary edema that we're going to be focusing on. We have cardiogenic and non-cardiogenic. So in our cardiogenic here on the left, we're going to have impaired cardiac function. CHF will increase capillary pressure. Some signs and symptoms that we'll see with this are going to be dyspnea, increased respiratory rate, SNS activation, and hypertension and tachycardia. As you can see here, the capillary bed is much wider, indicating that there is higher pressure and fluid getting into the alveoli. And here on the right, we have our non-cardiogenic pulmonary edema. This is going to have multiple causes: aspiration, neurogenic, opioid-induced, and POPE. We're going to go over those in a minute. For this one, we're going to have increased alveolar permeability. So you can see the edema fluid as protein rich. All right, so we'll briefly discuss the non-cardiogenic pulmonary edema. First is aspiration, which I'm sure we've all seen as well. Gastric acid is going to damage the type 2 cells in the lungs, and that's going to increase permeability. Signs and symptoms are desaturation, increased respiratory rate, increased heart rate, acute PAH and RV dysfunction. We're going to treat with 100% FiO2, bronchodilators, and PEEP. Neurogenic is typically secondary to acute brain injury, intense SNS activation leading to vasoconstriction and pulmonary congestion. Again, we want to treat with 100% FiO2 and give the patient antihypertensives. Opioid-induced pulmonary edema is going to be the quote-unquote stone chest. It's going to be a decrease in pulmonary compliance and increase in capillary permeability. So here, again, 100% FiO2, Narcan the patient, and intubate. All right, so POPE, the post-obstruction pulmonary edema. So there are two types we'll get into here in a second. But what is POPE? So it's going to be high negative interpleural pressure. It's going to increase venous return and increase blood volume. But the takeaway here is it's going to increase alveolar expansion, increasing interstitial fluid that seeps into the alveoli. So the two types that we're going to see, the most common is type 1. It's due to forceful inspiration during an upper airway obstruction, for example, like a laryngospasm or ET tube obstruction. And type 2, the relief of chronic partial upper airway obstruction, so getting a tonsillectomy. So some signs and symptoms of POPE are going to be rales. We're going to treat with oxygen. It's typically self-limiting, and we are going to provide a CPAP or intermittent positive pressure ventilation. The most common perioperative events that we are going to see are laryngospasm, ET tube obstruction, like a mucus plug or a kink, epiglottitis, and choking. So here we have a picture of laryngospasm, sudden closure of the vocal cords. All right, let's talk about PF ratios, which I'm sure we are also all very familiar with. So what is a PF ratio? A PF ratio is going to be taking your PaO2, which is what you get on your ABG, and dividing it by the FiO2, how much oxygen the patient's getting, but in a decimal point. And the ratio that you get from that is going to indicate whether the patient is a normal, having acute lung injury, or having ARDS, acute respiratory distress syndrome. So if the result of this equation is greater than 450, it's normal. But if you get something less than 300, the patient is going to be in acute lung injury. And if the patient is less than 200, they're going to have ARDS, acute respiratory distress syndrome. So if they're less than 200 to 100, it's going to be moderate. And if it is less than, this should be less than 100, it's going to be severe ARDS. Like I said, that I'm sure this is something that we've calculated day in and day out dealing with COVID patients, and evaluating how proning was helping a patient, comparing their PF ratios from when they were supine to when they were prone. And so I'm sure you're all very familiar with this. All right, thank you.